ready, because you know that I've already done a video on Crohn's for the clinical judgment pieces of recognize and analyze cues. You know there's 6 pieces of the clinical judgment. You know that I told you that yours truly, Dr. Shelley with HETV on YouTube, was going to make sure that all of my newest videos ran just like the test. In other words, any new video that I've done since the new test, the new NCLEX changed, it will reflect the new changes. So this video on Crohn's is moving on in a type of unfolding case study manner. Remember, we said most nurses, well, 100% of all nurses who take this new test, this Ngn Nclex, this next generation NCLEX exam, will have a minimum of 3 unfolding case studies. And an unfolding case study is different from case study type questions. An unfolding case study is going to give you 6 questions per case study. So each case study is 6 questions. There's 3 on every single test, no matter who you are and how many questions you get on the test. So if you get 85, which is the minimum, you still had 3 6-question case studies. If you get 150, which is the max, you definitely had 3, probably a lot more, but just hear me clearly. If you think about each case study as 6 questions, 6 times 3 is 18. If you only took the test and got 85 questions, 18 of those were case studies. So it behooves you to get really good at this, right? So you heard me say in the other video, and you do have to go to the other video. Now, how do you find any of my videos? You have to go to playlist. Playlist on HETV on YouTube is organized by subjects. This subject, Crohn's, is going to be organized under the chronic GI playlist. In other words, this is chronic. The patient's going to have it for a while, right? It's not like acute. So when you go under my playlist, you'll find all of the videos that I've done. And I mean, there's more than just Crohn's, right? There's like cholecystitis, there's GERD, there's gastritis, there's whatever is chronic, right? So you're gonna find all of those videos. And then of course there's just regular acute GI, and oh my God, well, that's a lot. That's peritonitis, pancreatitis, perforation, appendicitis, you know, bowel obstruction, liver disease, cirrhosis, blah, blah, blah. I could go on, but I won't, but you know what I'm saying. So let's talk about the case studies, because the first Crohn's video that I did earlier today, this morning, was based on recognize and analyze cues. This case study that this part of the case study, because that was recognize and analyze, the first 2 parts of the clinical judgment model. This part of the clinical judgment model, part of your case study, is going to be called prioritize hypothesis. And here's the thing, you guys, I told you I study this shit nonstop. Like, I'm kind of like neurotic about it, like, because I want to be the best in the world. And I think I'm pretty much there, but I can't let go. I got to stay on top, baby. You got to be thirsty up in this bitch. Now, so what I'm saying to you is I studied this, and here's what I figured out. When they say prioritize hypothesis on your NCLEX exam, they mean that they're going to look to see if you know how to take a condition like Crohn's and compare and contrast it with something just like it, ulcerative colitis. So whenever you see prioritize hypothesis, they are going to trick you and put like literally other features of a disease into this disease that they gave you as a select all. So you might have like a select all of these are all the things that the nurse recognizes as part of Crohn's, and then they'll throw some ulcerative colitis stuff in there. Yeah, so what I'm gonna do with this video, and the first video was Crohn's, but I kind of overlapped a little bit. No. Today, right now, as we speak, I'm about to show you that you've got to separate these 2 in your note taking. How do you do that? Let me show you. Everybody by now knows that I have CHELLYS NCLEX Prep. It's a link that I usually put on as many videos as I can. You tap the link, you go to the search, you put in whatever handout you're looking for, GI, maybe you want a bundle, like a self-study bundle. That's a Best Buy. That's like really cheap. I think it's like $389 for a self-study bundle. Like you get every handout. So every video that I've ever made has a handout, and you get them all for $389. But you know, stay focused. Here we go. You have the Oh My God packet. This was newly revised. I do want to make sure that you see that. Newly revised just a few days ago. And then the handout for this lecture is in your gastrointestinal packet, which is actually, if you would put on it, if you have one yourself, make sure you have chronic GI on the top of this packet. Now let me show you how to maximize your handouts. So inside this packet, just so you know, from this morning's lecture is Crohn's disease, right? So the whole page is Crohn's disease. But you might think, well, I don't have any room for ulcerative colitis. Yes, you do. You have to maximize your packets. So if you turn the page, once you see something that says occult blood, this is the page I use for ulcerative colitis, and I'll tell you why. It's ulcerative colitis that most likely has blood in the stool. Because ulcers bleed, honey. That's just what they do. All right, so we're going to get started because I got to hurry up because y'all got an attention span of a teensy wink. So I don't want to be standing here and you falling asleep and looking all half-cocked and crazy. So let's go on and get this party started, shall we? Now, again, you guys, for real, keep your notes separate. This is all Crohn's. This is all ulcerative colitis. Okay? All right, let's go. Let's hit it. Some of the features that I talked about in the Crohn's video before this one, I will fine tune for you if you're given one or the other, which column you should put it in. But let's start and remember what they share. We're trying to diagnose this, right? So what do they share? Here's what they share. They are, here we go, both chronic GI conditions. They are both inflammatory bowel diseases. They both can lead to colon cancer, colorectal cancer. There is no cure with regards to treating the condition with medications and different things. That's a caveat because there's a little bit of cure if you do surgery on one of them. But for your purposes, you need to know that there technically is not a lot of cure here, okay? Except for surgery for one of them. We'll talk. They are both autoimmune diseases. And what that really means is you and I talked in the neuro videos about autoimmune diseases, and I don't like to assume that you know what that means. So let me just real quick give you a couple little tips on autoimmune diseases. I have an autoimmune disease. My autoimmune disease is Graves' disease, hyperthyroid, right? Hyperthyroid. You could tell I'm hyper as fuck. So my hyperthyroid or Graves' disease, the way my little problem works with autoimmune is that my body developed antibodies to fight my thyroid. If you have type 1 diabetes, your body developed antibodies to beat up on your pancreas. If you have multiple sclerosis, your body created antibodies to eat up and tear up and beat up the myelin sheath or the covering of nerves. If you have lupus, oh, that's one of the worst, right? Your body developed antibodies to attack 4 parts of your body because lupus is blood, lungs, kidneys, skin, right? I mean, it's crazy. I could go on, but you get it. So what's this all about, right? Well, autoimmune disease means these patients have built antibodies to attack their digestive systems, right? So it's awful. Now, that's the big thing. The fact that it's self-attacking self. You're beating up yourself. Oh my God. Now, there is a time when we beat up ourselves and it's to protect us. It's anytime we get an infection or whatever, right? There's also a time that this will probably make more sense to you as being something you recognize and kind of get on a deeper level. Let's say that I've had plenty of students who get a kidney transplant. Let's say that one right now in my class waiting on a kidney, let's say that she gets her kidney transplant. What will she do initially? She will attack it. How do we keep her from rejecting and attacking and killing that kidney? We give the patient, my student, immunosuppressant drugs. In other words, medications to decrease your immune system so you don't attack this kidney. Same thing with autoimmune diseases. Not all of them, not type 1 diabetes, not thyroid disease, not, Hashimoto's or Graves. No, but these two, oh yeah. So that's important because when we start talking about treatment, which is not this video, you will see the autoimmune will come into play. So they're both autoimmune, okay? That's important. Now you know what that means. Self is attacking self, and most likely they're on medications to stop that, which are immunosuppressant drugs. Okay, moving on. What are they both have in common? They both are inflammatory bowel diseases. They both cause colorectal cancer. They're both autoimmune. They both have some genetic and environmental kind of connections or associations, right? Because we can't say it causes it, but for sure we see a genetic component to this, and a lot more with Crohn's, but they both have genetic overlay. Okay, here we go. They both have remissions and exacerbations, meaning sometimes you're feeling good, sometimes you're not. Sometimes remission or rest is what you're dealing with, and then sometimes exacerbation or extreme craziness. XX, R for remission, R for rest, exacerbation for extreme craziness, okay? They both have anemia. One has it worse than the other, we'll talk. They both have what we call extra intestinal problems, eyes, joints, skin, liver. Some have some parts worse than others, but they both do have a little bit of this. They both have diarrhea, some worse than others. They both have abdominal cramping. They both have electrolyte imbalance. They both have a low potassium. They both can be diagnosed in the teen years and the 30s. Some of these will differ on either side of those ages, but they both have the teens and the 30s. Okay, now we can get started with how they differ, okay? Here we go. And I start all the way at the top, so stay with your girl. This Crohn's disease, and hopefully, let me say this because I want to help you. Hopefully you kind of, even take an extra, I don't usually allow notebook paper. I want you to stay focused on the actual handout, but this might be one of the few times, and I do it with left and right sided heart failure or acidosis and alkalosis. So today might be one of those times where you take an extra piece of paper, notebook paper, and split it down the middle, put Crohn's on one side, ulcerative colitis on the other, okay? And so here we go. Now, Crohn's. What's going on with Crohn's in the actual digestive system? Check this out. Patchy ulcers. Yeah, patchy, kind of crazy ulcers. It's not the entire digestive system. It's patchy, right? It skips some places, it misses some places, it attacks some others, but it's patchy. But the problem is, even though it's patchy ulcers, like here a little bit, maybe a little bit down there in the digestive system, maybe some sores in the mouth, whatever. Even though it's patchy, it goes through all the layers of that area where it is an ulcer. So wherever there's that ulcer, it's going to go through every single layer. And that's why this patient is going to have a lot of problems with their actual intestinal wall and fistulas and fissures, because it goes through all the layers. So you could easily get a tunnel if it went through all the layers, right? It makes sense, okay? So patchy ulcers, but all the layers. The other issue with Crohn's is that it's the entire GI system, from the rooter to the tutor, from the mouth to the, well, you know, the ass. So that is Crohn's. Now come on, go with your girl. If you come over here to ulcerative colitis, it's more superficial, not so deep through every layer. It's more superficial, but it's continuous. Yeah, it's continuous. Like it's every part of that part of the body that it affects, which is a colon. It's every part of it. Ulcerative is a big tip on the test. Ulcers bleed. That's going to mean something later. Ulcers are big craters, right? Okay, so ulcer is going to be a big hairy deal. But guess what? So is colitis, because that's going to help you on the test. Colitis, colon only. Let's talk. This ulcerative colitis starts in the rectum, which is part of the colon, and stays in the colon. It would never be in the mouth. It would never be in the esophagus. You would never see it in the stomach. It's not hanging out at the duodenum. No, it's the colon, large intestine, period. Okay, that is huge, because you remember how we went through the body parts and we said digestion for Crohn's was mouth, esophagus, to the left was the stomach. Then you had the duodenum, jejunum, ileum, and the ileum was the last part of the small intestine. And as it goes over and enters into the large intestine, we said that's where most of the Crohn's was easy to be seen. The ileum, as it goes into the large intestine, is called a terminal ileum. So that was important, right? Because look, why was that important with Crohn's? Because if you think about the terminal ileum and how it goes into the large intestine, which is another word for colon over here, you go to the ascending, transverse, descending, right? That's your whole colon with the descending ending on into the sigmoid. Okay, so here we go. Where is there pain? Right lower quadrant in the terminal ileum, because that's all right here. Where is ulcerative colitis pain? Left lower quadrant. Let's talk. Didn't we say that ulcerative colitis started in the rectum? Okay, now let's backtrack. You may remember me telling you in a few videos ago, way back, the mnemonic of glass. And with glass, it was a quickie to teach you your body parts, remember? And so just because you might not remember, because that's how you be doing it sometime, let's just make our little glass and remind ourselves how it went. G-L-A-S-S spells glass, right? And we said that with this cross, you had to stand like this right by it to figure it out. Because if you did this, you messed up all the body parts. No, you had to do it like this and take this and superimpose it onto your belly. So what am I saying? Watch me do it, okay? From the sternum all the way through my belly button down to my pubic bone is that line right there. So what is this? This is your belly button, right? Right, in the middle is the belly button. That makes sense. Okay, but then we had to draw the other part of the line, this one. And so that's from flank all the way through the belly button to the other side of your flank, the other flank, right? Okay, so that's cool. Now watch this. GL, right? What side of my body is that? I'm on the right side of my body. GL, gallbladder, liver. We're good. A, appendix. You got this. S is over here, left lower quadrant, and S is up here. What are these two S's? Well, this one's easy. This is your stomach, and even though the spleen is not a digestive organ, it's also the spleen, just so you know. But the stomach is big because it's digestive. But then what is this S? Well, I affectionately, because I'm hood, what are you gonna do? I mean, come on. You chose to watch me. I didn't beg you. I'm hood. So down here in this left lower quadrant is shit. All right, I'll try to be professional. It's sigmoid colon. Is that better? Okay. Shit. Sigmoid. Now think about it, guys. Think. If ulcerative colitis starts in the rectum, what's in the rectum? Shit. What side of the body are we most likely near before we went to the rectum? Sigmoid colon. So where is there pain? Because it started in the rectum anyway. Left lower quadrant. You got it, baby. Left lower quadrant. Oh my God, that's huge. Oh, that's huge. That is a distinct difference between these two conditions, okay? All right, now let's do more, okay? Because I'm feeling it. Diagnostic tests and procedures. What diagnostic tests are better for some and not so much for others? To be honest with you, real world application. Both of these people, both of them, because we don't know what they have, right? Both of them need EGD, colonoscopy. Now, before you go out of your mind and go, what's an EGD? It's an endoscopy, okay? So chill. EGD, if I wanted to spell it out, esophagogastroduodenoscopy. But where did we say Crohn's was? The entire digestive system. So esophagogastroduodenoscopy. It could be anywhere in those body parts. What would the EGD do for this side? You're not going to see it. Because why? It won't be in the esophagus. Esophageal, gastro is stomach, duodenoscopy is small intestine. No, it's not going to be anything on the EGD. It's going to be all easy to see on a colonoscopy. EGD, colonoscopy. But because this is everywhere, you can't just say EGD. You have to say both the EGD and the colonoscopy for this patient. What will we see on the EGD colonoscopy? Cobblestone. That is big. Like, highlight it, put some stripper glitter on it, prick your finger and bleed on it, take the gum out of your mouth and stick it in it, spray the perfume around it, whatever you got to do to know that cobblestone appearance on the scope, the EGD or colonoscopy, is a classic hallmark sign. And that just means skipping lesions. They're skipping. They're not continuous. They skip all kinds of areas, making it look like a cobblestone. When we look at this patient, the ulcerative colitis patient, yes, we will probably do an EGD. Yes, we will. But that's not what diagnosis is. There are two ways to diagnose this easily. The classic hallmark way, and it is big, that you know that way is bigger than anything else, is obviously the colonoscopy. I just sat up here and told you it was the whole colon and continuous. So of course a colonoscopy is it. But what else is pretty good? A barium enema. Now, you know, an enema goes through your butt. They ain't gonna do nothing for this one, but it's definitely gonna do something for this one. And when you do a barium enema and you do the x-rays with the barium enema, you're gonna see, are you ready? Because you had cobblestone over here. This is a lead pipe sign. Well, some of you are just as perverted as I am. Lead pipe was like, that's what she said. I'm so sorry. I'm sorry. Sometimes I have to like break the monotony by telling jokes. And so you just have to pray for me because this is what I do. But lead pipe sign, that's ulcerative colitis. It's a smooth, No bumpy, lumpy stuff, just smooth, okay? But it doesn't, that's not really how your colon looks. It's supposed to be like rugged, like little rugged through there, like ridges and stuff. No, they don't have that. It's smooth, totally smooth, okay? Cool. It's crazy. All right, now you stand with your girl. What did I tell you earlier? Ulcers bleed. So what else will this patient have more than this one? Positive blood in the stool. Okay, that's kind of like a big deal, right? But you want to remember that colonoscopy is diagnostic. EGD is diagnostic, okay? Barium enema is helpful. Barium enema, no. Okay. Now let's look at something else. Remember how we said that this patient is diagnosed in their teens or in their 20s? I'm sorry, their teens or their 30s, like somewhere young. Oh, this one can even be diagnosed in childhood because it's more genetic than that one. So we can get a 9-year-old with this. Yeah, that's never going to happen over here. What is going to happen over here is we usually see the teens to 30s, like we said in the green part of the board, but you can also see it in 50s and 60s. So you know your girl old, 60 years old, I'm never going to get this if I haven't gotten it already, right? I'm not going to get Crohn's. But I mean, there's still time for me to show up with some ulcerative colitis. Let's pray not. I'm just saying that's how you're going to remember this, okay? So we're good. Now let's look at some more differences. When we're diagnosing both of these patients, and this is one of the things that they kind of share, and I'll break up a little bit of it, but they kind of share the lab part. You know, you do the diagnostic test, but then you look at the lab. Oh, and let me just say one more thing. Capsule endoscopy or magnetic resonance endoscopy is also part of what could be used for this patient with Crohn's, and that's because of the complications of fissures and fistulas. So again, we might do an MRI with basically an endoscopy. That's what MRE, sometimes we call it MRCP, you know. Capsule endoscopy is where you swallow this huge pill, capsule, and it takes pictures all the way through the digestive tract. That would be a good one for this one as well, okay? So just remember that. But let's do labs because labs are important. We know that with both of these patients, they're going to have all kind of labs. Now, how are they going to look? Well, what's a CBC? Complete blood count, right? What do you care about in a CBC? Red, white, and blue. What do I mean? Red blood cells, white blood cells, and blue is platelets. But do you really care about red blood cells? No, you care about hematocrit and hemoglobin. As far as you're concerned, that's the red blood cell. So when I'm looking at a CBC, a complete blood count, I'm looking at H&H, white blood cells, platelets. If you don't have platelets, you get black and blue. That's why I said red, white, and blue. That's how you're going to remember CBC. What are we going to see with this patient with Crohn's? Well, they're probably going to be anemic. In fact, I can almost guarantee you they're going to be anemic. And it's not from bleeding. No, that was this one. They're going to be anemic because they're not absorbing shit. Like they're not keeping anything that they need in their body because their condition affects the whole digestive system. So they're not absorbing nutrients. They're horrifying on paper, right? So they're going to be a little bit anemic. They may not be severely anemic, just maybe a little bit anemic, but they're going to be anemic. What about white blood cells? Well, they're both going to have anemia, which is red blood cells, hematocrit, hemoglobin. They're both, but this one will be worse. They're both going to have high white blood count. They'll be about equal with that. Platelets will not necessarily be affected with either. So what is the CBC difference? What is the complete blood count result difference? Anemia, anemia. Anemia from malnutrition, not absorbing nutrients. Severe anemia because they can hemorrhage, because ulcers bleed, because they can be a GI bleed, and they're losing blood, and plus they're not absorbing as much as they need to because they have diarrhea. You feel me on that? Severe there. Okay, so anemia, severe anemia. That's the take-home message. BMP, CMP. BMP means basic metabolic panel. CMP means comprehensive metabolic panel. What are those exactly? Well, a basic metabolic panel, a BMP, means a glucose, electrolytes, renal function. A CMP, or comprehensive metabolic panel, means all of those tests plus liver function. All right, so they are both gonna look like shit when it comes to their BMP, but I hope you're listening. Ulcerative colitis will have a horrible CMP because their liver is very often involved in problems with this condition. Their liver is bad, okay? They can have more liver problems than this patient, okay? So that's kind of important. Now, earlier when I did the Crohn's video, I talked about diarrhea as much as 20 times a day. Well, actually, their diarrhea for the average Crohn's patient is about 6 times a day. But if you have ulcerative colitis, it's 20 plus times a day. So let's look at that as a big difference, right? They both have diarrhea. And yeah, I guess, you could either one of these could have it 20 times a day, but you got to know which one is more likely to have it 20 times a day. This patient has malnutrition, watery diarrhea, 6 plus or less times a day. This patient, if you'll remember, I spelled this word for you, tenesmus, which means an urgent need to go poop. They both have it, but this is extreme. This patient has tenesmus to the nth degree, like 100% more than this one. So bad that if this patient doesn't make it to the bathroom, they're incontinent of stool and they know it, so they have a great fear, anxiety, and depression over it, okay? So tenesmus, and then think about it. When they have diarrhea, since it's 20 times a day, way more, 3 times more than Crohn's. When they have diarrhea, it's bloody and it's mucousy. You knew it was bloody because the ulcer thing, right? So blood and mucus. This one's more watery, every now and then some mucus, but more watery. This one is bloody, mucousy, all day, all night, no sleep, nothing. Uh-oh. So you having bloody stools all day. You have a very high potential of having a GI bleed, don't you? You have the very high potential of having a hemorrhage. That's why your anemia is much worse. It makes sense. For Crohn's, this Crohn's disease patient has every layer affected wherever there's a patch of ulcers. So if there's a patch of ulcers up here, it goes all the way through the bowel. So far through the bowel, plus it's a lot of small intestine, it can be, that it's eating the tissue, right? And so you can have abscess. We talked about that. An abscess is a pouch of infection. The abscess can burst and cause a tunnel, which is a fistula. And you can have microscopic tears throughout the whole colon where these different problems exist. And then because abscess, fistulas, fissures, and GI is dirty, you can easily get peritonitis and sepsis. That's Crohn's. You're not going to see fistulas and fissures and things like that over here in ulcerative colitis. No. Fissures and fistulas are here, not here. GI bleed and hemorrhage is here. Okay. Now, you got to remember what the function of the body was. The function of the small intestine was to absorb everything. This can affect anywhere in the GI system. Malnutrition makes sense. B12 deficiency, ADEK, fat-soluble vitamins aren't being absorbed. We're going to go back there. With ulcerative colitis, it's only in the colon. What's the purpose of the colon? Well, you may not know this, but the purpose of the colon was to absorb water, sodium, make poop, give it color using bile and bilirubin, and then store it in the rectum, evacuate it through the anus. Well, guess what? If you have ulcerative colitis, you are dehydrated because you're colon is not doing its job. It's diseased, remember? So it's not absorbing the water and you are dehydrated, but you're not necessarily typically as malnourished as Crohn's. Dehydration, malnutrition. Okay? When it comes to this patient with ulcerative colitis, would you believe that they do really well with diet? Diet doesn't necessarily help this one, but it helps this one more, okay? So they do better with diet. Now, our other issues that affect ulcerative colitis more is called perforation. You knew that because ulcers can bleed. Toxic megacolon. The colon gets so swollen and inflamed that it doesn't work hardly at all. And now you have what we call like a little bowel obstruction or something, right? It's just not working as well. It's not digesting. It's not pooping. Or it's pooping too much. So you know you got that going on. All right, so we can get toxic megacolon. Just remember those two words, toxic megacolon, okay? And then for this patient, now this is weird. You ready? For Crohn's disease, smoking is the biggest factor that makes us know it's going to get way worse. You're going to have all kinds of complications if you don't put that damn cigarette down. Not that you would ever encourage someone not to stop smoking. It's just that smoking has nothing to do with ulcerative colitis. It has everything to do with Crohn's. It has next to nothing to do with ulcerative colitis. But smart people have enough sense to know that if both of these lead to colorectal cancer and so does smoking, stop the shit. Just saying, common sense. But this one is more of a smoking issue. I hope I made that clear. Now, if you look at one more blood test that I didn't go over, they both have ESR-CRP. ESR-CRP. ESR is erythrocyte sedimentation rate. CRP is C-reactive protein, right? All those mean, and all you need to know that they mean, is those are inflammatory markers. That's what they are. They both have that. They both have inflammatory markers. So if this one's more dehydrated, what part of their BMP might be abnormal? Their BUN, because BUN, blood, urea, nitrogen, is a dehydration lab, right? And for this patient, their CMP, if we look at the CMP, their liver would be fine, but their albumin might suck, right? Because what's albumin? It's a nutrition lab. You got this, okay? Now, let's look at the biggest difference of all. Since this one is only the colon, and this is anywhere in the digestive system, patchy, all over the place, continuous colon only, technically, we have a cure for this one. But what's the cure? Take out the entire colon, you get rid of the disease. Doesn't that make sense? If I took your colon out, then ulcerative colitis is not possible. What would that entail? Well, we would call it a colectomy, removing the colon. And we would either do an ileostomy where you're wearing a bag. That's kind of played out. That's what we had to do back in the day. We do a lot more creative things now. I love working in my department because I get to see it all. We might want to create something called, hear me clearly because this is complicated, an ilioanal anastomosis. Ilioanal, ileostomy, anal, right? You're connecting the ileum. The ileum, what was that? Small intestine. You took out the entire large intestine, which was connected to it. You took that all out, but you connected the ileum to the anus so this patient could poop like normal. It's so cool. No bag needed. What is that called? An ilioanal anastomosis. Anastomosis just means you put two parts together. You hook them up together, okay? And then the outcome would be called a J pouch. That's what I see at work sometimes. A J pouch. A J pouch is created when we took the entire large intestine out, which is called a colon, and we connected the ileum, the last part of the small intestine, with the anus so you could poop normally, no bag needed. Oh God, I hope you heard that really clearly. But what about this one? Why do I have something down here for surgery? Here's our problem. 75% of everybody in this little area that has this condition, 75% need multiple surgeries. Multiple surgeries. That's sad because not one of those surgeries is going to cure them. It's only meant to improve their quality of life. Can you see how both of these patients would be depressed, anxious, stressed, overwhelmed, even sadly suicidal? You feeling me? That's sad. So I'm always blessed when I get to take care of these patients. There's lots of different departments that I work in, but it's all under one umbrella. But these are my infusion patients, and I absolutely make it my business to love on them, hug them with warm blankets, listen to them, talk to them, give them that extra feeling that I care, and that helps. They have a great afternoon when they do that, or a great morning, and we send them off letting them know that we do care. So, you know, don't just keep it all biological. Do some loving on people, right? Okay, all right. We are actually done with prioritize hypothesis. You know what's going to come next. Generate solutions, take some action, and evaluate your outcomes. Deuces, I gotta go work. I gotta do the next one, okay? So you just get your chart together and one side versus the other. Bye, Felicia.